Hopefully everyone's got a chair to sit on. We're going to be kind of covering two topics based on how fast we can get through the first one. And it's going to be, the first one, the main one, is going to be the application of the outcome measures that we have in here. So just a disclaimer, because sometimes this stuff gets put on YouTube and is shared with La Mirada, and actually some other clinicians sometimes. But it's going to be about using our outcome tools. Now, our objectives are over here when you can kind of read them, and it's going to be learning and explain the importance of these outcome tools to our patients. And when we're using these outcome tools, our primary goal is mostly to improve the patient's function, the impairments, and reduce their disabilities. So our job as rehab specialists is to become much more expansive, and we all know now that we can't necessarily continue working in the silos that we've done in the past. Like, for example, if somebody has an ankle diagnosis or a shoulder diagnosis, we're finding out that pain is a little bit more complex, that we have to expand beyond those silos now. It's no longer a single body part that we're seeing our patients for, but we're treating the entire patient with that body part impairment that's with it. Now, in order to do this, we have to learn these following objectives. As mentioned, number one, be able to learn the importance of completing these outcome tools and forms to give to our patients. Number two is the strategies on how to consistently collect these outcome tool data. Three is to analyze and interpret the outcome tool data. And then also to integrate the outcome tools into our documentation. So knowing these objectives, it sort of allows us to be able to appreciate the value of these outcome measures when we bring it into practice. By the way, this is sort of going to be like an interactive thing, so if anyone has any questions, if it does come up, sometimes it's still fresh in my head, the topic's still fresh out in the open, you can bring it up and sort of discuss it in here too. I'm going to start off by saying, how cool it is to be a rehabilitation specialist, especially in the field that we do. I still have a bit of a passion for it, and I think now more than ever we're needed during the time when people are becoming much more deconditioned with all the COVID. So there's multiple studies that sort of support APTA studies, the PT first thing that they're trying to push. And however, as cool as we are, there's a letter that came up to the editor-in-chief of JOSPT in 2018. And it brought up a point that this approach, neglects the fact that physical therapy interventions can be either high or low value. For example, attempting to replace a patient's opioid prescription, which is a low value, with physical therapy interventions like therapeutic ultrasound or dry needling will do nothing to solve the opioid crisis and will only damage the credibility of our profession. So I happen to agree with this author's statement in here, and what evidence-based practice recognizes as high-value treatments is usually, I think, the best strategy to be able to overcome a lot of the problems that come up. So it uses I think if you use high-value evidence treatments, it's the only way, I think, to improve functional outcome the best, without having long-term side effects. So also, based on the statement in this slide, if it isn't written, it didn't happen. If you look on there. And it would make no sense for me to degrade a high-value treatment if somebody's doing that with some kind of low-value documentation. So the documentation that we have is really important, because that's what supports us in a court of law. That's what also supports our plan of care and what we decide on when we're making these critical thinking, developing our treatment plans that way. So if low-value treatments have been found to be more harmful than helpful, I might be able to also argue that low-value documentation could also not be helpful. That's what all this fuss about the documentation that I'm presenting in here is about. Right? I think we began collecting this data about 8 years ago, and we've been using outcome tools for a while. And that's about the same time as when we started giving some of these services out to be able to apply them a little bit better. So an insurance company, it's become a requirement for them to be able to receive some kind of measures for improvement. And that's where I think these blossom the most, is because you can give them a number now, and insurance companies, they tend to understand numbers much more than they understand the reason for what our notes are written down. in the past, I've actually had insurance companies and adjusters call me to translate what I wrote down on my note, to have them figure out, okay, what did you just send me, and why should you ask, and why should I give you, the 6 treatments that you're asking for right now? But they seem to understand numbers really well, and I haven't actually had any adjusters having to call me recently in the last couple of years since starting all this stuff. So Mike L. presented an in-service around 2011, and I followed it up with a video presentation in about 2012 on how to integrate these outcome tools into our plan of care. So these outcome tools are the equivalent, I think, of radiography or imaging, to where if you only have one sample, which is like the one that we get and collect in the very beginning of an ODI, and you have nothing to compare it to, they're basically useless. You always hear like one radiograph photo or study is completely useless. You need 2 or 3 to be able to compare them to. So I also understand that human evolution is slow, but I do think it needs to happen if our practice is not going to become extinct in the future. During the last partnership council, we had one final one before we shut everything down. Now we're communicating through email. Lila presented a list of barriers that we need to overcome in order to get one step closer, I think, to what feels like more of an evidence-based practice. So the number one reason that she was sharing with us is that, and this gets like sort of the gold medal, you see it in gold over there, is that the clinicians feel like they have little or no value in their plan of care, and this keeps them from wanting to make time to have patients complete those outcome tools. In turn, it also doesn't convince the patient that it's important enough, because I think that patients can truly feel, and we communicate it out through our body language and our tones of voice, that these are either important or unimportant. So the silver medal goes over here to our clients becoming, they sometimes will refuse to want to fill these out because they don't find the value in it either. These are a bunch of random questions. This has nothing to do with my knee. Why are you asking me this stuff? And I don't even run or jog. Why are you asking me this stuff on an LEFS? The bronze medal goes to the time constraints that we all have when we're trying to manage everything within 30 minutes. So you almost have to make time for this because we don't have time when we're treating patients and when we're evaluating patients. So I was suspecting that what if we educated our clinicians on the value of the outcome tools, and when they get that, it'll carry over to making the patient feel like it's going to be worthwhile to fill out. So we often underestimate our client's ability to be able to sense this, and be able to read it. And there's a couple of studies I've said it shows that we actually underestimate our patient's ability to be able to learn and understand things we say. So this hopefully should allow us to make up for that time. So I want to be able to make sure that by the end we get an initial eval and we get a discharge outcome tool done in there. All right, so a show of hands, I'm curious, and you can raise whatever you want, like a foot or even a head. If you've had anyone refuse to fill out an outcome tool, like with me, I sometimes will get that. But has everyone here had every patient always want to fill out an outcome tool so far?
The desire? No, but they do it.
But they do it. They do it. Okay, wow. Now I've had like at least maybe 3 or 4 times where somebody will mention that to me. So because no one else has this problem but me, I will touch on this topic really lightly. One of the things I got was that I'm not filling this out. It has nothing to do with my pain. It doesn't have anything to do with the things I do on a daily basis. And usually my response is that you don't have to, but it may lead to potentially lowering the success of your rehab program because I may not be able to get the information to give you the best plan of care. So human metrics as far as being able to function with pain, especially a lot of the people that come in here, I'm seeing for pain. I'm not seeing them because I feel like it's stiff over here. My back can't move around very much. Every now and then I will get something like that, but the majority of people that come in here are usually because they have a painful back or a painful leg. So pain has gotten to be so complex that it can't be qualified in like an ICF category. It can't be biomechanical anatomic anomaly to where we can just focus on that diagnosis anymore. It has to be an entire person now, like I was mentioning. And that's why there's so many outcome tools that the SEC ends up using. Sometimes they tell me that they don't want to fill it out again, no matter what I told them, that they won't get the best plan of care. So I usually will have to disclose to them, you know what, you don't really have to again, but I can never give you the best of what I can provide in developing your plan of care scientifically. And as long as you're okay with receiving second best or third best treatments, something a little bit lower than the best I can give, then that's also fine. So we can also say that we can't necessarily extend your therapy anymore because it's an insurance requirement. But for me, that seems like it's not a really super good reason to tell somebody. It is simple and it is straight to the point, but it's very minimalistic. And I think if you were to just give somebody the outcome tool because that's a requirement for them to be able to continue seeing you for about another 4 to 5 visits, then there's no clinical reasoning that's involved, I think. We should be able to make those sound clinical reasons, and it should be based on some of the information that we receive in here. All right, so why are these metrics so important? During the PC meeting, the last meeting we had, I had a patient, and I thought it was interesting that this came up just before the meeting, who came in. She had a family emergency, and I was seeing her before COVID. And what happened was, COVID came, she had an emergency, she had to spend about 45 days on the East Coast. And while she was there, she wasn't able to do a lot of her things. She was able to travel, but at the same time, she was able to get herself strong enough, so she did well in traveling. Now, she thought everything had fallen apart. She thought that she had regressed and she had lost all her strength. Well, what happened was when I remeasured her during the reassessment over here, she actually had better results than the last time I did a reassessment on her ODI and her Orebro and on her Start Back tool. So meaning to say that, as disappointed as she was in herself, and that has a big factor to do with how well somebody does, is the depression that they feel, and a lot of these metrics end up capturing some of those things too. So we didn't have to start from the very beginning, which was really nice. And the best thing about these outcome measures, when you standardize an outcome measure like this, even though it has activities in there that the patient doesn't necessarily do, is that just about any practitioner anywhere in the world can see them. Whether you're a massage therapist, a physician, a nurse, an athletic trainer, personal trainer, any of those people, if you happen to follow an evidence-based practice program, they should be able to get any paperwork and they'll be able to flow in the same direction. The problem is when you have a single practitioner, maybe out of that group, and sometimes I'll hear this where, I'm also seeing a chiropractor, I'm also seeing a massage therapist, and I also have a personal trainer. And I've heard some clinicians mention that, you know what, you got to stop seeing one of those, or maybe you got to commit to me, or you got to commit to them, because some of the things we say may not sort of jive in there. Mm-hmm. If you have 2 evidence-based practitioners, it should flow anywhere, no matter what they do. Because any dietitian, any occupational therapist, or any massage therapist anywhere in the world will flow with whatever I say when they see the notes in there. They'll understand it right away. The problem is when you get 2 anecdotal therapists, they'll never be able to go together. And whenever there's a conflict of what one person is saying versus another professional saying, in the long term, it actually will make our patients worse. So it's really important that some of the things that I'm sharing here, if you happen to be seeing some of my patients and what I say versus what you say, has a big impact in the next 2 or 3 years of making that person worse with what's called thought viruses or nocebo effects. So I thought the Spine Center was actually really good because a lot of the practitioners and a lot of the things have been standardized in here. So any spine person that flows back and forth with any clinician in here should flow really well. I always make it a point to thank my client. I think it's like that's like step 1. Whenever they fill out these patient-reported outcome measures, because it does take a lot of time, it takes a while, and they have to sit there uncomfortably to be able to fit this stuff out. So when you thank somebody for that, it's because it means something to you when we can use the data later on. Knowing how to interpret this stuff, and sometimes the stuff that is in here, the content, is very intimate, medical stuff. So I think the first thing that we do is when we're going through the question that came up with why do we even do with a spine care patient? And this is one of the earlier meetings that we had back in maybe March, one of the last meetings before we went into COVID status. So some clinicians actually had no idea what to do with it. And maybe some of the questions were also coming up from La Mirada because there's a little bit less exposure to how spine care treatments were done. Maybe that was before we actually came over there and they saw some of the treatment plans that were developed. So evidence-informed practice has taken us a little more than about 10 years to barely get to where we're at today. And I'm hoping that some of the things we do right now can help boost it along a little bit more. So we're going to go through the top four outcome used in the spine care center, which is the ODI, Cerebros, Start Back, and the PSFS. And we'll have like other slides for that. But right now we may also go through some of the other things. And I think the global rate of change over here, that's something that you can use before the treatment, maybe even after the treatment. And you can find out, hey, if you use it before the treatment, how did you do from the last time you were here? And after the treatment, you ask them again, hey, how did you do after that treatment? It gives you a small picture and a snapshot of how that person's plan of care was working or not working. Does it need to be adjusted? And does the dosage need to be adjusted? So rather than asking, hey, are you 20% better, 50% better, 80% better? You know, what exactly is the MCID of 50% better? So it's a good ruler to be able to gauge somebody that got better or not better. But there's not a lot of research that's been done for it, so therefore it falls in the realm of anecdotal kind of evidence when you're practicing with something like that. The readiness ruler is something I use also, and this is to see if somebody's completely prepared. So that number 7, if they score an 8 or above on a scale of 1 to 10, we're finding out that the goals that the patient chooses, or the goals that you determine when you make your plan of care, are really important because it has to be meaningful to that patient. If it's meaningless, the chances of success drop a whole lot more. I mean, who's going to want to keep working so hard to get something they don't care about? It's a goal that they come up with, and most of them are, lately I've been getting a lot of grandparents in here, and they want to be able to carry their new grandson or their new granddaughter, and they can't lift them off the ground, and they can't lift them off out of the crib because their back is bothering them. So that becomes a really meaningful goal, that they'd be able to get on the ground, play with them, be able to get up from the ground, and still play with them and pick up things or pick them up again. Numeric pain scale, we're all very familiar with that. And then the Hooley's is actually a screening, it's a 2-item screening for depression. And it gives me an idea that, hey, does this person, do I need to refer them to a psychiatrist or psychologist? Because during COVID time is when I'm starting to get a lot of positive things. If you get 2 out of 2, and the first question would be, 1, during the past month, how often have you felt bothered, feeling down, depressed, or hopeless? And it's a yes or no. If they say yes, okay, I've been feeling that. I've been isolated. I can't see my grandkids. During the past month, how often have you bothered by little interest or pleasure doing the things that you like to do? You know, if that's a yes, that they haven't been doing a lot of those things, that's 2 out of 2. So usually when you get 2 out of 2, that has a very high sensitivity and about a moderate specificity for depression. And the third question, and there's not a lot of validation for the third question, but you'd ask them, do you want help or should I contact somebody? And if they say yes, that's a positive, and you would call it usually your favorite social worker down at the ED. So, of course, we have the ODI, and you're gonna be familiar with this by now since it's been 8 years that we've been using this form. And it was crowned as basically our gold standard for using at the Spine Center, and chosen out of all the other outcome tools because it's also the most popular that's used. Now, out of curiosity, who has seen this thing as far as who's familiar with what the scores even translate or mean when somebody has it in there? All right, so I see one head shake. What? I got one head nod. I got two head nods. Sold to that man. So, I think it's kind of good that somebody would be able to see the meaning of what they have, but at the same time, I'm looking at the language they use. This is like the ODI. I think has been around for like 40 years probably right now, and some of the language that they used back then probably needs to be reframed as something. Yeah, maybe it's crippling, but you're showing signs of enhancing yourself because you're starting to move in a direction that is getting better. So it may have to be sort of reframed when you explain some of the findings of these outcome tools. So this is our Oribro, and you can kind of see over here that when we fill this out, or when they fill this out and we interpret it back to them, you can kind of tell, hey, this person scored really high here. They have a fear avoidance issue. Now we can talk about, let's calm you down. Before we even start lifting or deadlifting or doing any of the stuff in here, before even touching the weight, I want to make sure that you feel safe with this. A couple of times I actually have patients who will watch another patient lift because it hurts them to watch another patient lift. After that, they'll watch me lift a couple of times. And the weights are large in here because they're standard size, and they look a little bit bigger. And there's a psychological reason for that. Is because when people start lifting weights that are larger and are heavier than they thought that they can imagine doing, it allows them to be able to overcome a fear avoidance cycle in there. So over here, this is their ability to be able to perceive return to work or perceive return. Maybe their housework, maybe the things that they do on a daily basis. This is distress over here and how stressed out they feel. Maybe there's things that are outside of physical therapy which have a massive influence in pain, especially when the pain has been there for maybe longer than 90 days. And if you're able to come up with some solutions for them, things that they can try out, they end up calming down. And a lot of times it allows you to begin doing more of the physical things. Now, a lot of the statements that you have when you're talking to somebody about pain neuroscience is absolutely useless without having a physical activity ingrained into it. It works really well when you have cognitive behavioral therapies and you have psychologists and psychiatrists treat these people with long-standing pain, but they're not in the position that we have where we can get them moving. We can move them around and they can actually lift weights and much better than their outcomes. All right, over here, you're going to show that if they score high in this section over here, this is your ability to be able to predict their sick leave, and that could be their attendance here in therapy. If they're scoring pretty high here, that means their attendance in therapy may be pretty low. Every time they come in, they may have a lot of missed visits. That's when you'd have a talk with them. Hey, you know what? It seems like you're having a lot of stuff going on over here. Is it better if we see you once every 2 weeks or once every 3 weeks? Do you think you can make that in? And that's where that readiness ruler comes in. If you scored on a scale of 1 to 10, how ready do you think you're able to come in and make it twice a month? And if they say, you know what, I scored about a 5 on it, and I'd have to ask them, well, what would make it an 8? How would you score an 8? What can I do? Can I give you the early morning times? Do you think you can come in after lunch? Is there something that is happening that maybe, we're going out of town, and when we come back, can we start then? And I'd be able to come in easily once a week if that was the case, and that would make it an 8. So that's how you'd use some of these questions in there. Pain, that is up here, and of course, that's again something that you're going to be familiar with. The start back, whenever you see this thing, you're going to notice that it's got when you look at the form of the start back, you'll see a number between all the numbers that you add up in there, and then you'll see a number between 5 to 9 on the right hand side of that scoring sheet. So if they happen to score a 3 or less, it puts them in a low risk category. This is supposed to be a disability category for them. And this is a medium risk, of course, and then high risk for disability is over here. Now what causes that to end up happening? It gives us an idea that if somebody scores a low risk on the start back over here, what you want to do is you want to either see them for maybe 1 to 2 visits. You can actually discharge them that day, but if they are here for a low risk, they may not need therapy. And if we continue to see them for 7 or 8 visits, we now put that patient in a position to make them worse in the future. So now they have a dependency that we built, that they need to see us in here when they could have done it really on their own. If they get a medium risk over here, they might need education on peripheral neuroplastic biology, of pain education. And they would benefit the most from that. But you would never give them central sensitivity education over here. If they score a high risk over here, they would need a combination of both. Central sensitivity and peripheral neuroplastic biology and pain education if they fall in this category. The ones that don't receive information like that, the ones that receive information like, well, it hurts because your hip is higher on one side than the other, or you know what, you have some degeneration in your knee, or you have some degeneration in your spine, you usually don't need that kind of information. And if you're not giving them the central sensitivity or something that is supported by science, there's a good chance that somebody who explains to them scientifically what happened will actually make them worse once they hear the two opposing information come up. So let's talk about, here's a list of outcome measures, PT and OT. So this is what everyone else uses. And I know we use the pen on our side, and I happen to like the quick dash a lot because it's something that has merged OT and PT together. There's sometimes patients I see with Edie or Rocky that have already filled out a quick dash, or if they filled out a quick dash with me, I'd be able to make a photocopy and just give it to them. There's no sense in having a patient fill out two different outcome tools just because one is a shoulder and one is an elbow. So it all translates to one thing, and that's how we can also make time to be able to do other things in there too. Quick dash, it's got an MCID of about 8 points. Neres Williams 2014 gave a great comparison to normative data from the general population score needing to be able to reach the minimal detectable change is about 95%. The DASH website has frequently asked questions, and I found 2 questions in particular that came up, and I'll kind of show you that thing later on. One of the reasons I heard about the DASH is when you fill that out, it has no meaning to the clinician. It's meaningless because they want to be able to get to their own goals and present that. All right, so again, because it's not standardized, if they happen to move from that person who calls in sick to another clinician who's seeing that patient, the non-standardized one will conflict. And so one of the questions that came up was if respondents didn't do a specific activity in the past week, for instance, yard work, and they're asking about that. The answer that the DASH website gives is that the DASH and Quick Dash are designed to measure the capacity to do things because we recognize that each individual may not have performed the actual activity during the past week as respondents to rate their ability to do the task. For example, if you had done that task, how much difficulty would you have had? You'd have to have them imagine that. And often patients will say, well, they didn't do it because they weren't able to do it. And such a response would equate to a score of 5, which is unable to know. The other question I thought out of the 2 were the top ones were, why are the DASH and Quick Dash not specific to my patient's affected limb? The answer is that they will evaluate the upper limb, the disability and the symptoms that are there, not necessarily what your body part is. Items are not attributed to the affected limb because at the level of disability is defined by the disablement process. Chet, 1994, Rodriguez, 1994, we want to know an individual's ability to do activities regardless of which arm, shoulder, or hand they use. The intent of the DASH and Quick Dash is to determine how much difficulty a patient has when doing activities, no matter how it's done. And so it revolves everything around function. And you notice I didn't go through a lot of the pain scale. I tend to naysay that thing in there because a lot of times when people ask, and this is a requirement that we have, this may change in the future based on what we're finding out about asking about pain scales. Whenever you ask about how much somebody feels like they're in pain, it usually will end up making the pain worse in the future, is what we found out. So what I do is I have to reframe that question. I'll ask about function first. My PSFS scores. How much easier is it for you to now pick up your grandchild? And if they give me a score there, then I'll ask, okay, well, I know this is not super important, but how much pain did you feel? And I try to play it down a little bit, only because if they think that the pain is more important, they will most likely perpetuate and become worse in the future in disabilities. So it's got the website over here that if you wanted to know more questions about the DASH, it'll be right here. All right, I mentioned several slides ago that this information was introduced by Mike L. in 2011, and I'm hoping it's been practiced to perfection, so a lot of this stuff you're probably really good at being able to determine a score and a goal, but you want to at least try to achieve something that's meaningful for the patient by making sure that you meet the MCID over here when you set your goals. So not that it just gets better, but you actually surpass it would be the best. And even if you don't, a lot of times they're not going to be able to, they're not going to base whether they're going to continue the therapy or not give you extra visits based on that, because there's also clinical reasoning. You know, the reason we don't have science-based medicine is because humans can't work in a scientific and only scientific, pure scientific-based medicine. If we did, we'd go by numbers alone and we'd have no clinical reasoning to be able to justify what we do. So it also shows the medical change scores to help us determine what we feel our clients have made a significant change. You know, a patient can get better, but if they feel like it's not significant, again, it has to be meaningful. And that meaningfulness is what you're trying to create when you're meeting these goals. So the region-specific score changes will also allow us to be able to better predict our current plan of care. Is it on the right track? Does it need to be adjusted? Does it need to be modified? Or did we find something that all of a sudden the person's decline in function was so drastic that we need to send them back to the physician because now we found something that is that may be a red flag in there. All right, so I do hope I made it clear, you know, as far as the evidence-based documentation that's necessary in order to be able to practice with best available evidence, and to further tackle the ability to be able to find time to be able to do this stuff. I was wondering if we could do some housekeeping, mostly on some of our treatment plans that might be able to free up time to fill out an outcome tool. So I placed it's kind of a decision chart, and I don't know, like Kyle, what would you put under high value as far as treatment goes in there?
Squats.
Squats? All right. Why is that high value?
Because you do it all the time.
Do we do it all the time? Yeah. We got to get up out of the car. So again, the reason it's high value is because a lot of science and rehabilitation medicine have determined that when somebody becomes physically stronger and uses something that they need to get easier to do on a daily basis, that is also meaningful. And if you look, there's a chart behind you that when you load the squats, not just do the squats, they actually have better results out of it too. Anything, as far as low value, let's see, Dennis, any low value stuff?
Low value, just only going based on pain.
All right. So how would you set up a treatment? Like if you have a treatment plan full of if you look at your treatment grid, what would you choose in there? You know, as far as putting something in that's high value versus low value.
Maybe something with like very low resistance.
So the low value, I mean the low resistance isn't necessarily a bad thing, but it's usually done within about the first couple of days after somebody injures themselves. Then a lot of the research will show that the heavier loading, again, once it becomes later on down the line, starts becoming much more valuable than that. But no, there's still value in the low resistance stuff. Some of the things that like modalities, I don't know, Vicky, any low value stuff? Shoulder shrugs, those are usually pretty good.
I said E-stim.
E-stim?
Unless they're like high pain.
Actually, E-stim is not too bad. I would probably put it above ultrasound if we're talking about modalities. For the last, 15 years, if you look at the practice guidelines of physical therapy, they have recommended not to use ultrasound for pain. That's in there. So if it's still continuing to be used right now, I think it's perpetuating sometimes to the reason why if we look at the chart, we have these macro studies that show how much money we're spending on trying to fight pain and reduce it, and how much pain is actually getting worse the more money we're spending on it. It's a little bit shocking that some place like Australia is doing better than us at maybe half the cost of what we're spending. So they're having patients who are getting better with less money versus us. So more money doesn't necessarily make better results in the end. And then, yeah, I don't know, anyone else want to volunteer? I'm going to go with Ben. What's a high value treatment, you think?
All sides, arm braces.
There's a treatment thing I'm gonna mention is number one on the list is listening to the patient is a high value treatment, because when somebody listens to what they say, it enhances everything. It allows the patient to be able to express what sometimes they've not been able to say to other clinicians in there. Making a rapid therapeutic alliance, which means that they have buy-in and you make a strong connection with that patient, has made a strong value in treatment plans in there. So I know it's not written necessarily in our treatment plan, but the things that we say, even with like for example the ultrasound, we've noticed that whenever we have an ultrasound machine that's detuned to where it's offering nothing versus one that actually works, the same results happen about 3 to 6 months later to the patient as far as what their function goes. So out of all the settings that they had in there, I think the second highest and the second best was, I think the first best was like 0.5 or something on the ultrasound machine. The second best was when the machine was completely shut down and only the lights and sounds were beeping that were on there. The rest of the other settings had lower outcomes in comparison. Yeah, so if there's any other questions that come up, I know it's a lot to sometimes swallow, especially when some of the science is hard, it's cold, and there's no emotion, and science doesn't care. So sometimes it just kind of comes out at you, and because of the way that we've been taught in school, some of the things that we're practicing right now may have been different than what we thought was the way to go that was taught in school. So it's sometimes difficult. And I want to make sure I don't sound like a dictator up here, because sometimes even good science will get refuted if I present it too roughly in there. So I want to make sure everything it's not against anyone that's in here. These are, I guess, the references. Feel free to have a joy in reading them over the weekend if you so dare. I don't know, anyone want water? There's some coffee in there if you want to stop in. It's Hawaiian hazelnut. The patient brought it in. It's fantastic. It made my heart sing this morning.
So the only main difference is just make sure the functional outcomes work.
Yes. So you're not even going to be considered for being worthy of being read if the outcome score before and the most recent one is submitted to have the patient extend, for authorization for insurance purposes. So that's the big difference that we have in there. The font may be a little bit different. And if anyone has any comments toward it, I think it's pretty much finalized based on all the chefs that were trying to cook on this pot of stew. But it was rough coming up to being able to find enough space and everything. And if there is any questions, you're always welcome to come up in there.
So if there's no significant change between before and after, as far as wanting to extend it, does that mean it's less likely to get considered?
It might go in your assessment part. If there's no significant change, a lot of times what happens was, okay, I had a patient that came in, they had to stop coming in because of COVID and they weren't able to do stuff. Their gyms were shut down. They weren't able to go to the gym. They had a death in the family. That goes on the assessment part. Hey, this person got worse, or this person actually didn't improve because of all this stuff happened. And that's what makes science backed and not a purely science medicine work, is because you can take the science and then you can have a rationale behind the reason, of what human behavior caused it to not work out really well. No other questions on the form? No one wants to do any squats? Anyone want to plank for the next 2 minutes? Mario? All right.
Thank you.
Mario. I don't know, that's what it reminded me of, because you have a mustache or Luigi, all right, sorry. So in the next 10 minutes, if no one wants to do any coffee drinking, push-ups, or planks, then this is the thing about pain. As far as the biggest thing I've seen so far is that sometimes when I'm talking to a patient, especially if they're seeing my patients, this is where the conflict starts to happen. They say that this is a 12-question pain neuroscience questionnaire that you have to be able to get at least 80% on. And if you can't get at least 80% on this test, you should not be answering a person's question about pain. That's what they recommend. Because you might give them information that may make them worse and perpetuate their pain to increase in the future or their disability. So let's take a stab at this. Out of show of hands, I was going to see if, how many think the first one is true here. It says, is it possible to have pain and not know about it? All right, who thinks it's true? In a show of hands. All right, true, one. All right, true. The rest of you, who thinks it's false?
I think it's a trick question.
It's a trick question.
If they're have numbness,
Yeah.
that would be my only question. If they have numbness, will they really feel it? But then the question still is, will they have pain? Is it pain? I don't know.
Okay.
I don't know how to define
Or the
it.
people that say, oh, I only notice it when I'm not doing anything.
Okay. So, would you say, and I need to see hands this time, who absolutely has no idea about if it's true or false? Okay, one, thank you, brave sir, and all the other liars in the room. All right, who has no idea though? Or who, if you took a stab at it, I'm curious. So,
False. Probably makes most of us.
all right, so this one is false. It is. So it's possible to have pain and not know about it would be false. So pain is something that we perceive and we feel. If you don't feel it, that point in time, you have no pain.
Yeah.
And I know it's tricky as these sound. These are all scientifically backed questions about what's been found out in neuroscience about what causes pain to happen. So 2 is when a body part, when a part of your body is injured, special pain receptors convey the pain message to your brain. Okay, we've got a true.
False.
Yep, that's true.
False.
We got a false. All right, good. So far the trues are winning, and the clueless have hands down so far. we have no hands. But I don't know. False. Okay, false. If you got false, that is correct. So your body part, when it's injured, the body part doesn't have any pain receptors. If you dissect a body in anatomy, you're not going to be able to find any pain receptors at all. What we do have is nociceptors, and we have emergency signal generators, which are those nociceptive cells that are made. So only nociception or only danger signals can actually go to the brain. Number 3, pain only occurs when you are injured or at risk of being injured. False. All right. The false has got it right. Yes. So, yeah. Pain can actually occur even when you're not injured. I have a lot of patients that come in here and I ask them, hey, did you fall? Did you lift something? Did something hit you? And they said, no, I had pain come up all of a sudden in my knee. I woke up or I was just getting up from the couch. They had no injury and yet they feel pain. So yes, that is false. Number 4, when you are injured, special receptors convey the danger message to your spinal cord. True or false? You should have a Jeopardy song in the background. Who can beatbox that? Beat? No beatbox? All right. All right, what do you think? When you are injured, special receptors convey danger messages to your spinal cord.
Nociceptors, posterior column, I would say.
That would be, I guess, true, right? Anyone else? True? Anyone else?
True.
Got Mike bobbing his head in the back.
True.
All right, yeah, that would be true. All right, so those are those nociceptors we're talking about that send the emergency signals or the danger signals up. Special nerves, number 5, in your spinal cord convey danger messages to your brain. True or false?
Say that again one more time, Ken.
All right, so they convey danger messages up to your brain. Ding, time's up.
I don't think that. No. No.
This one is true.
It is.
Yeah, this one is true. So I'm hoping you guys don't feel bad about this because a lot of this stuff.
This is making me feel a lot of pain.
Do squats, it'll help. So there's secondary neurons that are inside the spinal cord that when you have the primary neuron, when you have the primary nociceptors send the danger signals, they get relayed, almost like you get tagged. They pass the baton to secondary neurons that will continue to send the danger signals up to the brain. And when the danger signals received, the brain is processed. Hey, is it a lot of danger or is it a little bit of danger? Then it helps the brain decide, do I need to cause pain there or not?
Dr. George
So,
Pig,
number 6,
17400.
nerves adapt by increasing their resting levels of excitement. So meaning to say that we all have these resting levels, and you only hear this action potential coming up when it gets sparked off. New nerves adapt by increasing the resting levels of excitement. All right, I got some head nods over here. I'll even take nonverbal language over here. What do you think, Tom?
True.
Yeah, that is true. That is true. So we didn't say that, like, I'm over here, and all of a sudden I'm like, Dennis, what's up? All right. That'll actually increase your excitatory levels. Well, sorry, Mario. Not him. I think I woke 3 people up on that side. So there's a good chance that Mariella's nociceptors or danger receptors are ramped a little higher than Dennis's. You know, they're in here. A lot of times I'll watch this, like if Halloween comes up and you're watching a scary movie, and all of a sudden, oh man, somebody forgot, the washing machine went off in the garage. No one wants to go get the laundry in there after the scary movie is up. So it'll actually excite it even more. And this has a tendency, when you're fearful or afraid, of elevating or amplifying emergency signals that come out of the body. Especially if you have a body part that is already in danger, and it feels like, okay, this is our most dangerous spot, this is our most vulnerable. I need to amplify that area even more. So now your brain is going to receive more dangerous signals from that spot. Right, number 7, chronic pain means that an injury hasn't healed properly.
That's false.
That is correct. Yep. So a lot of times people get amputations, and they still continue to feel pain, even though they no longer have the ligaments there. So number 8, worse injuries always result in worse pain.
Absolutely false.
Yeah. They did this study in England and also in Australia, to where one of them didn't believe that you go to the emergency room, the people who have the most amount of traumatic and life-threatening emergencies will report the least amount of pain, compared to the ones who are non-life-threatening will report the highest amount of pain. Descending neurons are always inhibitory. That is correct.
Absolutely false.
So descending neurons, your brain can actually turn down and inhibit stuff, and it does that by creating opium sometimes and morphine. Number 10, we're wrapping it up. All right, so keep your eyelids open, gang. Pain occurs whenever you are injured.
No.
Any good examples for that? No, again, that sample I gave where people will come in and they reach for a paper clip on their desk and pull their back. You know, for sure, something just didn't explode in there. All right, so when you injure yourself, the environment that you are in will not affect the amount of pain you experience as long as the injury is exactly the same. Thank you, Dennis. Last one. The brain decides when you will experience pain. I would say. We got more head nods than.
So that's true, Ken?
That could be. That's still counted as a yes, right? So, yes, it's true. Now, this is the dangerous part. Is that I try to tell people that. I try to tell people in a way that the brain is the only thing that can decide that the body has pain. Meaning to say that you can cut a leg off, you can cut a back and a spine out of there, but you can still continue to have pain. The only time you cannot feel pain is when they cut the brain out. Because there's nothing to be able to process the information, there's nothing to be able to create that stuff to go into the body now. So congratulations everyone, collectively, you now got 100%. So you should be able to answer these questions really well, that if somebody asks about, hey, why is my knee hurting? Why is my elbow hurting? You can't necessarily tell them that a single anatomic anomaly that does that. Well, you got degeneration in there. You know, it is inflamed. But I get people in here with inflamed knees that are measuring like 10 degrees hotter than the opposite knee. They're twice the size of the other knee. They don't feel any pain either. You know, so it doesn't necessarily mean that just that happened. So you can't necessarily say that, well, it's because your knee's inflamed. It's because you may not have a lot of emergency signals that are being sent up to the brain, and now the brain is probably thinking that not a lot of emergency signals not a lot of emergency signals mean that there's not a lot of threat to the body, and when there's not a lot of threat to the body, that's the biggest indicator that we have so far that decides how much pain somebody feels. Not the back, not the knee, not the ankle. All right? Any final thoughts? Last minute coffee run? Yes. And thank you everyone for staying awake. Hopefully this was helpful to everyone that was in here. Thank you for the applause.